So we'll start with infectious diseases of liver today. The first topic is pyogenic liver abscess. So for the liver to get infected, it needs some source, right? So that source can be an outflow tract of the liver, which is a biliary tract, or it could be a inflow tract of the liver, which is a portal vein, or one more inflow tract to the liver is hepatic artery. So it could be from the hepatic artery, it could be from the portal vein, or it could be from the biliary tract. Plus, because liver is lying in the peritoneal cavity, there can be a direct spread to the liver from any of the organs. Also, because liver is situated in the abdomen, any blunt or penetrating injury to the liver, in fact, any trauma, be it iatrogenic or non-iatrogenic, that can also cause an abscess in the liver. And finally, some causes are not known, so they are cryptogenic. So these are the causes for the liver abscess. So it could be a biliary tree infection. These are the source of causes for the liver abscess. So it could be from the biliary tract, it could be from the portal vein, it could be from hepatic artery, which is systemic infections, or it could be a trauma to the liver, either iatrogenic or non-iatrogenic, or it could be cryptogenic, where the cause of the abscess is not yet found. Out of all this, the most common source for liver abscess is a biliary, and the portal vein is the second most common source. Right now, what are the infections of the biliary tree? So it is mainly ascending pyogenic cholangitis. Right? So ascending pyogenic cholangitis, where the infection ascends from the CBD to the liver, or it could be because of biliary tree obstruction. This biliary tree obstruction, in case of Asian population, the most common cause in Asian population is because of stone, obstruction due to a stone, cholelithiasis. In West, it is mainly due to malignancy, or it could be a Carolus disease, or it could be biliary ascariasis. Anywhere there is an obstruction, see this biliary tree is rich with bile, and bile is a very good medium for the E. coli to grow. And majority of the anaerobic organisms can grow very well in this bile. So whenever there's an obstruction, there's bound to infection happen. And once infection happens, that leads to cholangitis. And if this cholangitis spreads, it will eventually enter into the liver and cause pyogenic liver abscess. Or any surgery on the biliary tree, or bilioenteric anastomosis. So all these are the causes and the route through which the infection can enter into the liver. The second most common cause is a portal vein, right? So portal vein infection, just like there is ascending pyogenic cholangitis, it is pylophlebitis. So pylophlebitis can lead to the liver abscess. And earlier in children, the most common cause is infection from the umbilicus. So when they used to cut the cord of the umbilicus, they used to apply some cow dung to this umbilical cord, and that would lead to omphalitis. So this omphalitis was a major concern for pylophlebitis and pyogenic liver abscess. And then in the earlier days, it was acute appendicitis, right? Because appendicitis was not as easily diagnosed as today because of the investigations, and patients used to present very late. And this acute appendicitis would lead to portal pyemia, and from portal pyemia, there would be liver abscess, but these causes are reduced now. Now, any tributary of the portal vein can carry the infection from the draining organ into the liver. So, for example, appendix would be carried by the ileocholic vein. So, similarly, typhlitis would be carried by the portal vein. The inflammatory bowel disease could be carried by the portal vein. Diverticulitis could be carried to the portal vein. So all the draining areas, the pelvic inflammatory disease could be carried to the portal vein. Sometimes even thrombosed hemorrhoids, when they get infected, that could also be carried to the portal vein. And even pancreas, so acute pancreatitis can also lead to portal pyemia. The acute pancreatitis can also lead to splenic vein thrombosis. Right. So all these are the factors or the features through which the portal pyemia is carried to the liver. And then hepatic artery. You know that hepatic artery is a systemic circulation. So because this hepatic artery represents systemic circulation, the major sources of infection from the systemic circulation would be from the bone or from the lungs or from the heart. So it could be osteomyelitis, it could be pneumonia, and it could be endocarditis. So all these lead to systemic bacteremia, so that are carried by the hepatic vein into the liver, and these are usually seen in patients who are immunocompromised, right, whose immune system is compromised, or in case of children who suffer from chronic granulomatous diseases. In such patients, the systemic route of infection causes pyogenic liver abscess. And then coming to trauma. So trauma could be a non-iatrogenic trauma, which could be a penetrative trauma to the liver, or it could be a blunt trauma to the liver, which eventually causes to hematoma. Hematoma, because of its compression, will lead to ischemia. Ischemia will lead to necrosis. And you know, whenever there is a necrotic body, there is chance of infection. Or it could be iatrogenic trauma, like hepatic artery embolization or thermal ablative procedures. So when these are done, the hepatic parenchyma is necrosed at that area, and that would be the cause for the liver abscess. And then there would be a direct spread. Right? So this direct spread would occur from the structures that are nearby. For example, there is a gallbladder. So acute gangrenous cholecystitis would lead to liver abscess, or a perinephric abscess can lead to liver abscess, or there is subphrenic abscess can lead to liver abscess, or there's a perforation peritonitis, viscous perforation peritonitis. All of them, because they're in the vicinity of the liver, they can lead to the direct spread causing liver abscess. Right? And sometimes, even if all these causes are investigated, we do not find any cause. So that is called as cryptogenic liver abscess. So cryptogenic liver abscess can happen when, number one, you could not find the abdominal cause, right? Because majority of that is from the biliary tree and the portal vein. So you are expecting an abdominal cause, but you could not find the abdominal cause. Or second, there was an abdominal cause, there was some infection in the abdomen, but by the time they came and presented with liver abscess, by the time the liver abscess developed, this abdominal infection had resolved by themselves. So either abdominal cause couldn't be found out, or abdominal infection had already resolved by the time they presented with liver abscess. Or third is, sometimes there is transient. So anywhere, somewhere there's infection in the body. So this infection will lead to transient portal or hepatic bacteremia. So that is transient, but the bacteria will lodge there, and eventually later in the later period that can lead to abscess. So these are all the wide causes that can cause a pyogenic liver abscess. But the most common source remains the biliary tract, and the second most common source is the portal vein. Right. Now, this liver abscess, pyogenic liver abscess, is usually seen in patients who are above 50 years of age, and male and female is almost same. It is just that males are slightly more affected than females. It is 1.5:1, and it is seen over more than 50 years of age. And most often it involves right hemiliver. For that matter, any infectious diseases which spread from the gut to the liver, they involve right liver, because as I told you that the portal vein has got a long left branch which runs transversely, and a short right branch which enters more vertically into the liver. So because of this arrangement, the laminar flow is more towards the right hemiliver, and that is why, because of this easy access to the right liver, most of them are seen in right liver. Almost 75% of the pyogenic abscess are seen in the right hemiliver, and about 25% are seen in the left hemiliver, and rarely there can be a caudate lobe abscess. About 5% of the abscesses are seen in the caudate lobe. And this could be a unilocular abscess, or it could be a multilocular abscess. And these abscesses, 50% of these abscesses are solitary, while 50% of these abscesses are multiple. Right? So if it is a multiple abscess, these abscesses have increased risk of recurrence or residual disease. And so 50% would be solitary, 50% would be multiple. It could be unilateral or it could be multilocular, and usually it is a right hemiliver that is involved. And sometimes these abscesses may also result because of infection of metastasis, right? Infected mets, or sometimes even the primary malignant diseases of the liver. So these can undergo necrosis, and these necrotic mets can get infected, and that can also lead to the liver abscess. If it is because of mets, usually it will be a multiple liver abscess, right? So when it comes to microbiology, the polymicrobial abscesses are more common from the portal vein. So if the portal vein is the source, then polymicrobial abscesses are most common. And these polymicrobial abscesses, the most common organism would be E. coli or Klebsiella. Now this Klebsiella can lead to gas forming abscess. Right? And in about 3% of cases, this Klebsiella can lead to endophthalmitis. Right? So the risk of endophthalmitis is much increased if the patient is diabetic or immunocompromised patients. Right? So this is one. And second, if it is systemic, S for S, it is usually single, that is monomicrobial. Portal vein is the source, polymicrobial, obviously because the gut is the reason there. And if it is single, it would be usually systemic, and that would be a Staph aureus. Because from the bone, from the heart, endocarditis, Staph aureus is the most common cause. Right? So sometimes, if the patients are immunocompromised, in such patients, there could be tubercular liver abscess also, and there could be fungal liver abscess also, if the patients are immunocompromised. Then, what are the clinical features? So, because there is bacteremia, so the patients will obviously have fever with chills, and because the liver is involved, there is pain in the right upper quadrant, and there will be jaundice. This is called as the classical triad of the liver abscess: fever with chills, right upper quadrant pain, and jaundice. But this is seen only, all the three are seen only in 10% of the patients. But because the liver is infected, there will be tender hepatomegaly. Because of congestion, there will be hepatomegaly, and because there is an abscess, it will be tender. So about 50% of the patients will have this tender hepatomegaly, and patients present with prodromal symptoms. Right? So there is weakness, fatigue, and then there is nausea, vomiting. All of them are there. Now, if this abscess ruptures, that can lead to subphrenic abscess. So when it leads to subphrenic abscess, then the diaphragm will be involved, and the patients will have pain at the right shoulder tip, they will have cough, and they will have difficulty in breathing, dyspnea. And if the abscess ruptures into peritoneal cavity, if the abscess trickles down further, and that will lead to the features of the peritonitis. And sometimes there can be reactionary pleural effusion. Even if it does not rupture into the pleural cavity, because there is an infection close by, there is reactionary pleural effusion, and because of this pleural effusion, the patients will develop shortness of breath or cough or chest pain. Sometimes the left-sided abscesses, they can rupture directly into the pericardium. Where they develop features of pericarditis. So these are all the features that develop depending upon in what stage the patient is presenting. Right? So when you investigate in the blood investigations, the WBC will be raised and all the enzymes will be raised. SGOT, because liver parenchyma is involved, SGOT, SGPT will be raised. And if it is a chronic infection, sometimes there can be chronic infections, chronic liver abscess also. And you know that the chronicity manifests as anemia, and hypoalbuminemia. And sometimes INR will also be deranged. INR will be high. Right? In acute, it is easy to find out the cause, but in chronic, usually the cause remains cryptogenic. So these are the blood investigations. And you can also send a blood culture and the pus culture and sensitivity. Now, if you get a radiological investigation, so if you take a chest X-ray, because of the reactionary pleural effusion, so there is pleural effusion, and because of this pleural effusion, the lung is collapsed. And because there is abscess, one of the diaphragms, hemidiaphragm, will be elevated, right? So the hemidiaphragm is elevated, then there is pleural effusion, and the lung is collapsed. And as the disease progresses, there can be atelectasis, which can even further progress to pneumonia. So all of this can be seen in the chest X-ray. And X-ray erect abdomen is taken. And this X-ray erect abdomen, anywhere in the body, if there is an abscess, there will be air fluid level, right? So you can see an air fluid level in the X-ray erect abdomen in the liver, and there can be portal venous gas. So there can be air seen in the portal vein and an air fluid level seen in the liver. So then comes ultrasound of the abdomen. So the first investigation would be an ultrasound of the abdomen. So when you do this ultrasound of the abdomen, the abscess is either it is round or sometimes it could be oval also. And because it is an abscess, inside of that will be hypoechoic. And it has got an inflammatory wall. So because of the inflammatory wall, there will be rim echoes. So the abscess cavity itself is hypoechoic, but you will be able to see some echoes on the periphery of the lesion. And the investigation of choice could be CCT abdomen and pelvis. And once you do the CCT abdomen and pelvis, you will see that again the same thing is reflected in CCT abdomen. This is hypoattenuated. It does not take any contrast. So inside of the abscess does not take any contrast, but the outside of the abscess has got a intense wall enhancement, right? So the wall is intensely enhanced while it is hypoattenuated. This is what differentiates it from a amoebic liver abscess. In amoebic liver abscess, there is no wall enhancement, rather there is perilesional edema. But in a pyogenic liver abscess, there is intense wall enhancement with hypoattenuated inside of the abscess. Right. So once you are done with the investigations and you have diagnosed, this is very important to differentiate a amoebic liver abscess and a pyogenic liver abscess, because the treatment of the pyogenic liver abscess is mainly drainage, while the treatment of amoebic liver abscess is mainly medical management. So that is why it is necessary to differentiate these two before proceeding with the treatment. Once you diagnose that it is a liver abscess with all the imaging studies, then you send the blood for culture and sensitivity, and you aspirate the pus and send for culture and sensitivity. Right? So once culture and sensitivity is sent, you put them on antibiotics. Right? So because most of them are from the biliary tract and the portal vein, which are usually polymicrobial, you need to give an antibiotic that would cover both gram positive, gram negative, and anaerobic. Right? So earlier they used to give ampicillin should cover gram positive, and then amikacin for gram negative bacteria, and then metronidazole for anaerobes. But now there are good third generation cephalosporins available, and you can combine this third generation cephalosporins with metronidazole. So any of that can be initiated, and once the antibiotics are initiated and supportive measures are taken, then the under ultrasound guidance, the abscess is aspirated. And it is always better to insert a indwelling catheter. That is, a pigtail catheter can be inserted percutaneously under ultrasound guidance into the abscess cavity. And because this has got a pigtail, so it will be straight in the sheath. So when it is in the sheath, it will be straight. And as you withdraw the sheath, once the pigtail is in the proper cavity, as you withdraw the sheath, this will form the pigtail, right? So as it forms the pigtail, it remains in the cavity and it does not come outside the cavity. right? So that is why a pigtail catheter, indwelling catheter is placed, and then you continue antibiotics for 2 weeks. For at least 2 weeks, the antibiotics should be continued. Right. But sometimes the complications of this liver abscess would be, sometimes there would be rupture of this liver abscess, as I said earlier, or this liver abscess can recur. So the recurrence rate of this liver abscess is very common if there are multiple abscesses. And if the abscess that was trained initially was a huge abscess, right? So increased size of the abscess, multiple abscess, or the underlying cause of the liver abscess is not treated, or in case of immunocompromised patients. So in all these cases, there is a risk of recurrence of the liver abscess. If it recurs, then again aspiration is done. If aspiration is not effective, indwelling catheter is placed until it is completely resolved. Nowadays, laparotomy is rarely needed for uh, liver abscess. Even if it is ruptured also, the primary management would be to insert a drain into the abscess cavity and to insert a drain into the abdominal cavity and give good amount of antibiotics. This would take care of the ruptured liver abscess in the peritoneal cavity also. But if the patient is going into the worsening state of peritonitis, then a laparoscopic lavage could be done, usually avoiding laparotomy. Right? So laparoscopy is a very good and decent alternative to treat even a ruptured liver. This also, if it is pyogenic. Right? So this is all about pyogenic liver abscess. Any doubts till now?
No, sir.
Amoebic liver abscess. It is always uh, ideal to differentiate a amoebic liver abscess from a pyogenic liver abscess because the management strategies are totally different. So, pyogenic liver abscess, the primary treatment would be drainage of this abscess, either surgical or by percutaneous drainage. But an amoebic liver abscess, the primary treatment is medical management, right? So, amoebic liver abscess is usually caused by Entamoeba histolytica. There is one more familiar organism, that is Entamoeba dispar. Right. So this dispar species, it usually causes self-limiting diarrheas. So both of them lead to colonic infections. From the colonic infection, the dispar causes a colonic infection where it causes self-limiting diarrhea, especially in male homosexuals. But it does not lead to the liver abscess. It just stops there. It resolves. But Entamoeba histolytica, it causes colonic infections. From this colonic infection, it goes via the portal vein into the liver, and there it causes amoebic liver abscess. So, in contrast to the pyogenic liver abscess, the pyogenic liver abscess, I told you that it is usually seen in the age group of more than 50 years, but amoebic liver abscess is usually in the age of 20 to 40 years. And the pyogenic liver abscess, male to female, is not much of a difference. It's just 1.5 is to 1. So it is almost same, rates are same. But amoebic liver abscess is very, very common in males compared to females. It is almost 10 is to 1, right? The menstruation in females is supposed to be protective against this amoebic liver abscess somehow, right? So that is why the risk of this amoebic liver abscess is increased in pregnancy. So the male sex and during pregnancy and young individual of the age of 20 to 40 years. And if there's an immunocompromised state, if they are diabetic patients, if their socioeconomic status is low, and if because it is mainly from the fecal route, if the living conditions are terrible, then there are high chances of colonic infections through which it can lead to the liver abscess. So all these are the risk factors, and also in patients with alcoholic cirrhosis, where immunity is again compromised. So these are the risk factors, and these are the group of the patients in whom amoebic liver abscess is more common. Right? So for this amoebic liver abscess, for this Entamoeba histolytica, the humans are definitive host. Right? So it gets converted from the cyst to trophozoite form in the humans, and they induce infection in the humans. And the route of transmission is fecal-oral route, right? So from any of the intermediate hosts which shed the cyst into their feces, and this cyst is consumed by the humans by the fecal-oral route from the contaminated food and contaminated water. This cyst will enter into the stomach. Now, in the stomach, from the acid also, this cyst doesn't get degraded, and this cyst will now enter into the small bowel. And in the small bowel, this cyst gets converted into the trophocyte. But this trophocyte does nothing in the small bowel. It does not cause infection in the small bowel, neither it invades the small bowel. This trophocyte keeps on passing and it will enter into the large bowel. So once this trophocyte enters into the large bowel, in the large bowel, this trophocyte will invade colonic mucosa. And then as it invades the colonic mucosa, it will enter into the submucosa. In the submucosa, it has an option to enter into the lymphatics or into the portal vein, but it selectively chooses to enter into the venous system. Right? It does not enter the lymphatics. It enters the venous system, and all the blood from the gut is drained by the portal veins. So from there, it will enter into the portal vein, and from the portal vein, it will enter into the liver. Right? So all that it has done in the gut is enters. Nothing happens in the esophagus and stomach. In the small intestine, the cyst gets converted into trophocyte, but the trophocyte do not cause infection there. It enters into the colon. There it invades the colonic mucosa. Because it invades the colonic mucosa, it causes destruction of the mucosa. There is diarrhea. So this phase of the abdominal phase, luminal phase of the organism will be here. And from there, it will not enter into the lymphatics, rather enters into the venous system. And as it gets drained from all of this into the supramesenteric vein, then enters the portal vein, then it will enter into the liver parenchyma. Now, as it enters the liver parenchyma, now in the liver parenchyma, this trophocyte will cause cell adherence. It will adhere to the hepatocyte and it will activate and it will cause the hydrolysis. Right? It keeps on hydrolyzing the cells. So all the cells will be hydrolyzed. As the cells undergo hydrolysis, they will undergo necrosis. Right? So this is a kind of liquefactive necrosis. So there is liquefactive necrosis, and there are sinusoids. When the sinusoids are destroyed, that will lead to the bleeding, and then because of destruction of all the intracellular organelles, there will be protein debris, right? So this liquefactive necrosis with blood and protein debris, these three together give the characteristic anchovy-sauce appearance. And there is as the liquefactive necrosis happens in the center, there are these invasive trophocytes which are surrounding them. The invasive trophocytes will be surrounding the liquefactive necrosis, and this just keeps on spreading and spreading and spreading until it reaches the Glissen's capsule. Now, this Glissen's capsule is resistant to the hydrolysis. It does not allow it to spread from the Glissen's capsule to beyond the Glissen's capsule, where it restricts the invasion of these trophocytes because that is resistant to hydrolysis. Unless there is a secondary bacterial infection where the Glissen's capsule is breached, and then it can spread further. Now, as this happens, the body will initiate the inflammatory response and it will send in the neutrophils. So the neutrophils will enter and they try to destroy these trophocytes, but these trophocytes will cause the hydrolysis of these neutrophils also. So the neutrophils are not efficient in destroying these trophocytes, in turn get destroyed, hydrolyzed by these trophocytes. And then the body secretes IgA. It activates the humoral immune system, and this secretes the IgA antibody against these trophocytes, right? So then eventually the T cell mediated response happens, and this is the main immunity against these trophocytes. So IgA is the bridge till the T cells arrive. Right? So this is how the Entamoeba histolytica causes infection. So it enters via fecal-oral route, enters into the stomach. It is not degraded there, enters into small bowel, gets converted into trophocyte form, invades the colonic mucosa, enters the venous system, enters the liver via portal vein. There it causes hydrolysis. The liquefactive necrosis, the blood from the sinusoids, and the protein debris together give an appearance of anchovy sauce. The neutrophils come in, try to restrict the infection, but these neutrophils are also hydrolyzed by these trophocytes. And eventually the IgA antibody is produced, and then T cells come, and T cells are the main inflammatory response against these trophocytes, right? And the infection keeps on spreading until it reaches the business capsule. Now, how do these patients present? So these patients also present with fever because there is liquefactive necrosis happening, fever with chills. They present with right upper quadrant pain. And these patients can present in acute presentation. Sometimes there could be chronic presentation also, because if there is an abscess and the body is effectively able to limit the spread of this abscess, and there will be a fibrous tissue which is formed around this abscess, and this fibrous tissue will slowly become calcified. So there can be even calcified patients also. So these patients will not have any symptoms apart from occasional abdominal pain, right? In acute presentation is dramatic, right? So you call it as acute if they present within 10 days, and you call it as chronic if it is already crossed 14 days. So after 14 days, the fibrous tissue has resulted in causing the limitation of the spread of the abscess. Now, the pyogenic abscess, I told you that it is 50% of these pyogenic abscess are multiple, and 50% of these abscess are solitary. The same is true if it is a acute abscess. So acute amoebic abscess, again 50% of them are multiple and 50% of them are solitary. But a chronic abscess is usually around 80% of them are solitary. So there is a single lesion which is usually at the periphery. And as I told you, because the left portal vein is of longer length and it is of transversely oriented, and the right portal vein appears to be a direct continuation of the portal vein. It is more straight, and the laminar flow is more in the right portal vein. So usually it is natural tendency of any organism to enter into the right hemiliver. So 80% of them in chronic are usually solitary, and when they are solitary, they are usually in the right hemiliver, which is most commonly involved. Overall, the right hemiliver is only most commonly involved. Right? So here again, it is necessary to investigate these patients thoroughly. So you get a blood investigation done. There will be leukocytosis, and if the abscess is huge enough to compress the biliary tree, there would be again rise in the bilirubin also. Right? Again, the liver enzymes will be raised. But the most common abnormality of the liver function test is elevation of PTINR. Right? So the rise in the PTINR is the most common LFT abnormality seen in these patients. Here, luckily, because it is a single organism that is causing, you can detect the antibodies against this. Right? As I told you that secretory antibodies are formed against these organisms, the antibodies could be detected. That is what is positive serology. Take the serum and you detect these antibodies by enzyme immunoassays. So that will be positive. And sometimes an antigen could also be detected. Right? So antibody could be detected. The antigen could be detected in the pus also, or in the blood also. You don't get anything. Finally, you aspirate the pus, and in this pus, you can detect this antigen of the organism. Right. So this is about blood investigation. Radiologically, X-ray would be same, right? Because there is an abscess in the liver. So one of the hemidiaphragm will be elevated, and if it gets ruptured or because of reactionary pleural effusion, there will be fluid in the thoracic cavity, and the lung will be collapsed. Right. And if you take ultrasound, I told you that in a pyogenic liver abscess, the ultrasound would be showing a rounded lesion or an oval lesion. But here in the hepatic amoebic liver abscess, usually it is a oval lesion at the periphery, right? So it is a oval lesion at the periphery, which is abutting the liver capsule. And this, the contents are hypoechoic because it is an abscess. Here also, because it is an abscess, the contents are hypoechoic. But here in the pyogenic abscess, there are rim echoes present because the neutrophilic infiltrate is there. The rim echoes are present. But here, all these neutrophils are destroyed by these organisms. The rim echoes are not present. That is a major differentiating factor in the ultrasound. The ultrasound is also not sure. You need to get a CCT abdomen and pelvis, which is again the investigation of first. So as I told you in pyogenic abscess, because there is abscess inside and there is a wall outside, there is a clear-cut enhancement of the wall. So there's enhancement of the wall on the outside, and then there is a hypoattenuating lesion on the inside. But here there is only hypoattenuating lesion inside. There is no enhancing wall. The wall enhancement is not there. Rather, there is perilesional edema. Right. So this helps us to differentiate. Now, with this also, it is not able. We are not able to differentiate. Sometimes a gallium scan can be done. Right. So a gallium scan can be done. So this gallium scan is taken up by WBCs. Right. So in what happens in pyogenic abscesses, there are these WBC neutrophils infiltrate which are present within the abscess cavity also. So because these neutrophils are present within the abscess cavity, now that those neutrophils will take up this gallium and there will be positive heat signature. But in case of amoebic liver abscess, the neutrophils are not present inside. So inside there are neither the bacteria is present nor the neutrophil is present inside the abscess cavity, and that is why these do not take up any of the agent. Right. So the gallium scan will be negative in amoebic liver abscess while it is positive in a pyogenic liver abscess. Even with all of this, you are still not able to diagnose the amoebic liver abscess. Then there are two options possible. The first option is to give a trial of antihelminthics. Right? So anti-amoebic drugs are given, and if the patient improves, there is improvement in the patient, you can continue these drugs. But if there is no improvement in these patients, or it is deemed the trial of the anti-helminths is not appropriate, and there's strong suspicion of pyogenic liver abscess, then you can do a percutaneous drainage of this abscess. So percutaneous aspiration of the abscess is done, and you get this abscess, you send this abscess for culture and sensitivity and microscopic examination. Right. So here there will not be any WBCs, and the culture should be negative because there is no bacterial infection, and then the antigen should be positive, right? So this will confirm the diagnosis. Once the diagnosis of amoebic liver abscess is confirmed, largely unless complications happen, the treatment of amoebic liver abscess is largely medical, right? So the medical treatment, the drug of choice is again metronidazole, given at a dose of 750 mg thrice daily for at least 10 days. Right? So metronidazole is given 750 mg thrice daily for at least 10 days. Right? So this will resolve the symptoms of the patient within 3 days. By 3 days, patient feels better, pain reduces, the fever episodes come down. Right? But for ultrasound to get resolved, it may take anywhere between 3 months to 9 months, right? So, for example, if you treat these patients for 10 days and you ask them to come for follow up after 1 week or 2 weeks, so ask them to come for follow up after 1 or 2 weeks of discharge, there would still be some radiological evidence of abscess present, but it is fine. So, radiologically, to clear the abscess radiologically, it will take at least 3 to 9 months, but clinically, patient's improvement is seen within 3 days, and the metronidazole is continued for 10 more days. So apart from metronidazole, you can give another other drugs like secmidazole can be given, tinidazole can be given, even chloroquine can be given. But chloroquine is a little less effective compared to these imidazoles, and sometimes intramuscular injections of emetin are given. So emetin hydrochloride intramuscular injections are given, but only thing is you should be careful about CVS because it has got the cardiac side effects. Right? So once this liver abscess is cleared, now the trophozoites in the liver are destroyed, but this patient is still continuously shedding the cysts in his stools. So the patient is still a carrier. So the patient has now converted from a sufferer to a carrier. So to eliminate this carrier stage, you need to give the luminal agents. Right? So these luminal agents would be paramomycin, biloxonate furoate, or iodoquine. So hydroquinone, paramycin, duloxetine fuellate are some of the luminary agents that can be given, and this the patient has to be put on this for a course of 1 to 2 weeks after the liver abscess is cleared. Right. So this will completely eliminate the carrier state of this patient. And what are the complications of this? So the complications are if there's a huge abscess, it could cause the compression of the IVC, or it could cause the compression of the biliary tree, or the abscess could rupture. So the abscess could rupture and it would lead to peritonitis. It could rupture in the pleural cavity, or it could rupture in the pericardial cavity. So if it ruptures in the peritoneum, it will cause peritonitis. Pleural cavity, I told you already. So there will be pleural effusion. There will be collapse of the lung, there will be atelectasis, pneumonia. If it ruptures in the pericardial cavity, there will be pericarditis, there will be pericardial effusion, and if it is too much, it can lead to the cardiac tamponade. So all these ruptures in the pericardium are usually from the left side of abscesses, and that's why they are usually rare. So even when it ruptures also, the peritoneal abscess can be mostly drained by ultrasound guided drainage. Right? So if it is diffuse and it is not amenable to ultrasound guided drainage only, then you do a laparoscopic drainage. Right? And pleural cavity abscess can be drained by thoracocentesis by putting an ICD tube. And the pericardial cavity, it can be drained either by pericardial aspiration or by a diagnostic pericardial window, depending upon the size of the abscess and the effects of tamponade.